Okay, let us get started with today's PAM webinar, where I'll be talking on caring for kids with head injuries. So let us have a quick run through on the statistics that are available in our neighboring country, which is in Singapore. So as you can see in the slide, in the KK Women and Children Hospital, back in 2011 to 2015, we noticed that the causes that cause head injuries in children are mainly due to fall, which contributes to about 71.8%, and that equivalent to about 2/3 of the causes. And next in line is the motor vehicle accident that contributes to 11.7%. And the remainings are due to sports injuries and non-accidental injuries that contributes to about 1.6%. And some of the key facts that I would like to share is in this study done in the Singapore KK Women and Children Hospital, they took in about 149 children, and they noticed that almost 41% of the injuries happen at home, while the remaining half of these injuries are due to road traffic accident. How about other countries then? So if based on a literature review done in the States, in Tennessee, in 2016, the worldwide incidence of pediatric traumatic brain injury ranges broadly, with most reporting ranging between 47 to 280 per 100,000 children. And it was noticed that male children are higher in predominance to suffer from traumatic brain injury compared to females. And a bimodal age group distribution is often described, with very young children involved, ranging from infancy up to about 2 years of age, and the second peak occurs during adolescent age group. And mild TBI with a Glasgow Coma Scale of 13 and above constitutes more than 80% of the injuries, and up to 90% of all these injuries are associated with negative imaging. So around 10% of all cases of traumatic brain injury are severe TBIs. In Asia, pedestrians were most commonly injured in motor vehicle accident. And 20% of children with severe head injury had also accompanying cervical spine injury. Majority of head injuries occur in the very young. If less than 2 years old of age, then 80% of the deaths are due to non-accidental injury. So do bear in mind, if a child come into you as traumatic brain injury and they belong to the younger age group, especially less than 2-year-old, remember about non-accidental injury. Okay. So now, why are children prone to head trauma? So let us have a quick run through on how are the differences in pertaining to anatomy. So in the pediatric age group, the risk of head injury is higher in younger children. Why is that so? The listed in the slides are the reasons of why are they more prone to the injuries. Children have thinner skull, they have more pliable bones, and their sutures are open. This means that their brain will be able to accommodate the raise of ICP initially before the signs and symptoms starts showing. And they have weaker neck muscles and ligaments, but they have a larger head to body ratio. So when there is acceleration and deceleration injury, head trauma tends to occur, and this will cause brain parenchymal injury. And not to forget, they have a higher center of gravity as well. And with all these anatomical differences, it can lead to serious injuries without fracture. How about physiologically? So physiologically, in children, they have higher brain water content compared to myelin. So when this happens, any acceleration or deceleration injury will lead to brain parenchymal injury. And not to forget, Children have a lower SPP, which is a systolic blood pressure, as well as a lower mean arterial pressure. That means they will also have a lower cerebral perfusion pressure. And they are, in the pediatric age group, they are more prone to hypovolemia, especially if it is a large intracranial bleeding. And this is particularly more common in younger infants. Okay. So, how about the cerebral hemodynamics in pediatric head trauma? So we have to bear in mind that children have their sutures will be open up to about 12 to 18 months of age. So once the sutures have closed around that age, the child's cranial cavity will behave like an adult with a fixed volume. That is only when we can use the formula of the cerebral perfusion pressure is equivalent to the mean arterial pressure minus your intracranial pressure, for us to measure what is the raised intracranial pressure is. And in children, the most common cause of raised ICP following head injury is cerebral edema. So one of the special consideration that we need to bear in mind is in infants with head injuries. So in infants, their unfused sutures will allow the cranial volume to increase initially. Thus, the symptoms and neurological signs may occur later. How about the pathophysiology of a traumatic brain injury? So the outcome depends on the severity of the initial injury, whether it is due to a primary injury or some of us we call it the primary insult, and the extent of the subsequent damage due to the cerebral edema, cerebral ischemia, or even inflammation, which can cause a secondary insult. So initial stage, there will be damage from the shearing and tearing force on the neurons, the glia, and the blood vessels. And this will trigger a cascade of responses, including the biochemical responses, the metabolic responses, as well as cellular changes. And all this will lead to mitochondrial dysfunction and loss of blood-brain barrier integrity, which eventually lead to the primary injury of the brain. So what are some of the primary intracranial brain injuries that we know of? So as you can see in this slide, a child with a traumatic brain injury, they can have focal brain contusions, and they can also have a variety of intracranial hemorrhages. As you can see at the slide at the far corner, that is an extradural hemorrhage. And then they can also have subdural hemorrhage. And some children might have a subarachnoid hemorrhage, and they can also have interventricular hemorrhage. So when we talk about primary intracranial injuries, what is the physiology behind it? So it can cause, when a primary injury occurs, it will cause hypoxic injury, and it can followed by seizure or any neural dysfunction from central apnea. And all these are oftenly seen in inflicted head trauma. Another type of traumatic brain injury that we commonly talk about is about concussion. So this is one of the most common form of traumatic brain injury. And usually mild to moderate traumatic brain injury, they won't have any radiographic evidence of injury. The child can present to you with headache, nausea, or vomiting, or difficulty in concentrating, or even personality changes. And bear in mind, this will only happen in older kids. And usually in concussion, it is due to neuronal dysfunction and axonal injury, which is usually transient. But some can also lead to long-term sequelae. And the general management is physical and cognitive rest, as well as symptomatic management. Okay. And not to forget, another type of traumatic brain injury that we need to be aware of is abusive head trauma. As we can see in the news nowadays, non-accidental injury or abusive head trauma is getting more frequent. And this is one of the common cause of death, especially among children younger than 12 months of age. And what are the other associated findings that we can find if we are suspecting a child with abusive head trauma? You can look for retinal hemorrhages, which is very common, about 60% to 85%, though it is not pathognomonic. And the reported mortality of abusive head trauma is as high as 23%. And majority of the children that survive this event will have some components of a neurological deficit. So what are some of the risk factors for abusive head trauma that we need to look out for? So when we obtain history from the parents or the caretaker, we need to look and dig into any risk of perinatal illness. Is the child having some birth defect, or any history of inconsolable cry, and it was written that male gender has a higher predominance for abusive head trauma as well. As for the family history, you will look into depth about any usage of drug or alcohol abuse in the parents, or the parental age is fairly young, or any social or family disruption or family separation event that is happening, or any history of abusive history in the family. So these are some of the risk factors that we are able to obtain when we get the history part. And as for abusive head trauma workup, you will need to do a thorough physical examination, an ophthalmological examination, and you will also need to send some laboratory investigation to rule out any risk of coagulopathy. And of course, for us to diagnose an abusive head trauma, a CT brain will be warranted. And later on, once the child is more stable, a full skeletal survey needs to be done as well. After we talk about primary intracranial injuries, then secondary intracranial injuries also need to be bear in mind, because the secondary intracranial injuries happen when there are injuries to the brain cell after an original insult. And it is a major contributor to the overall morbidity and mortality in traumatic brain injury. And the goal of patient management here is to optimize the cerebral oxygenation and metabolism, as well as to minimize the secondary insult. So listed here are some of the general management for us to minimize the factors that can lead to an increase in the intracranial pressure or cerebral edema, as well as cerebral ischemia. So if a child presents to you with a traumatic brain injury, we need to manage and ensure that all these components are being kept. You need to avoid hypoxia, maintain the child in a normal capnia, and then maintain normal tension, maintain a normal glycemic state, as well as a normal thermic state, and the avoidance of seizure as well, which I'm going to talk in a while. So what are the initial management of head injury in children? So of course, the initial management involves the primary survey and management. And how do we approach the primary survey? We will be using the mnemonic of C, A, B, C, D, E. So C is the catastrophic bleeding. So look out for any scalp laceration, any scalp bleeding, which can cause hypovolemic shock, especially in the infant stage. Okay? Once you have cleared the catastrophic hemorrhage, and then you will assess the airway. So ensure there is a patent airway and at the same time maintain a C-spine immobilization, because the statistic shows that up to about 20% of children with traumatic brain injury can have a cervical spine injury. And once you settle the airway, you will move on to breathing and ventilation. Here you will need to provide a high flow oxygen to prevent hypoxia, and then look out for any indications for intubation. And if the child is intubated, you will aim for a PCO2 of 35 to 40 millimeter mercury and a PO2 of more than 80 millimeter mercury. Okay. And in circulation itself, ensure there is 2 large bore cannula and aim for a normotensive. And in children with traumatic brain injury, we do not practice any permissive hypotension. In the disability, we need to do a thorough assessment on the Glasgow Coma Scale, or sometimes we will use the Pediatric Glasgow Coma Scale, or even in an initial setting, you can use the AVPU. And I'm going to talk a bit about this later on in my subsequent slides. So in disability, you will also need to assess the pupil size, the equality, the reactivity of the pupils, and then any abnormal posture in the child, and do not ever forget glucose. And in exposure, ensure the child is properly exposed and look for evidence for any base of skull fracture and prevent hypothermia. So this is the pediatric modified Glasgow Coma Scale that I wanted to share. So as we know, way back in 1974, the Glasgow Coma Scale for adult has been established. However, for pediatric modified Glasgow Coma Scale, there are some components that is a bit different. So in a normal Glasgow Coma Scale, we will assess the eye response, the verbal response, as well as your motor response. However, in the pediatric modified Glasgow Coma Scale, as you can see here, the difference is some component of the verbal response, and because in younger children, they are unable to talk. So we can only assess them based on their cries and their body language. So the verbal component in the pediatric Glasgow Coma Scale is different. And there is some studies done in the UK where a cross-sectional study done to assess whether GCS is better or AVPU is better, or are they equivalent in assessing the level of consciousness of children with head injury. So what they have found out is that the use of AVPU is beneficial for initial assessment of children with head injury, but are not sensitive enough for ongoing monitoring. That means we can use AVPU for our initial assessment, but during the continuous reassessment, we need to use a Glasgow Coma Scale in order to have a more precise gauge of the disability of the child. And listed in below are the AVPU component and the GCS equivalent level. There is always a question as well, whether mild traumatic brain injury is classified as a GCS of 13 up to 15 or 14 up to 15. So as we know, in adults, minor head trauma or mild traumatic brain injury is defined as a Glasgow Coma Scale of 13 to 15. However, for children, there is some slight differences. As per shown in the PECAN trial, the risk of a clinically important intracranial hemorrhage is increased with lower GCS for pediatric patients. That means in pediatric patients with a GCS of 15, they have a 4 to 7% risk of having a clinically important intracranial hemorrhage. But when the GCS is dropped to 14, the risk of clinically important hemorrhage has increased to 10%. And if the GCS drop further to a 13, then you can see the risk has increased double to 20%. So according to this Pediatric Emergency Care Applied Research Network, which is the PECAN study, the definition of minor head trauma or mild traumatic brain injury, we are using the Glasgow Coma scale of 14 and above. These are some of the definitions that I would like to share with you all. So we have a minimal or trivial TBI. That means a Glasgow Coma scale of 15 with normal neurological examination and no signs of skull fracture. Then we have a mild traumatic brain injury that constitute a GCS of 14 to 15, and this constitutes about 80% of patients. Moderate traumatic brain injury involve the GCS of 9 to 13, and it constitutes about 18% of pediatric population, while severe traumatic brain injury is where the Glasgow Coma scale is 8 and below, and this constitutes about 2% of patients, but the mortality rate is as high as 30 to 40%. And there is also another definition that we need to be aware of, is what we call clinically important TBI or clinically important traumatic brain injury. So based on the definition, a clinically important traumatic brain injury means that the brain injury that leads to death or any intubation for more than 24 hours, any neurosurgical intervention, and any hospital admission of 2 nights or more. So once you have a patient or pediatric patient that comes to you with a traumatic brain injury, we need to gather information. So you need to ask, you need to find out what is the age group, how is the mechanism of injury, what is the presenting complaint, and of course later on obtain a proper ample history. And look for assess the GCS, look at the pupils, look for any lateralizing signs or abnormal posture, look for other injuries that can lead us to signs of traumatic brain injury like fractures, scalp hematoma, or evidence of base of skull fracture. And then you need to consider whether this child would require an imaging to be done or observation. Okay? So these are some of the mechanism of injuries that can happen. Child can fall from the cradle, where some bigger kids who sleeps on a double-decker bed can get their head hit by a ceiling fan, and then motor vehicle accident, which is fairly common, and these are some signs of the base of skull fractures that we need to look for. So how about imaging modality? So if we are to decide what are the most appropriate imaging modality that would be suitable for a child with suspected traumatic brain injury. So we have a wide range of imaging modalities available. You have the ultrasound, the X-ray, the CT, or the MRI. Okay, so let us go through each one of it, and we will come to a conclusion which imaging modality would be the most appropriate. So ultrasound, yes, for ultrasound, the advantage is that we can look for intracranial bleed if the operator knows how to do it, and it is a non-invasive and not expensive. However, from ultrasound, we are unable to look into the brain parenchyma properly, and it is hard for us to detect any fractures. How about the other extreme end, the MRI? So for MRI, as we know, MRI is quite extensive. So definitely the advantage is that you will be able to look at the brain parenchyma itself, the soft tissue, and it will be an extensive imaging investigation that would be able to be done. However, the disadvantage point is that very few center has this access to MRI, and it is very time consuming. So it is not appropriate to be used in an emergency or a urgent setting. Okay? So that means it leaves us with two modalities left. One would be the skull X-ray and another one would be the CT scan. So in skull X-ray, yes, skull X-ray has a lesser radiation and it can be done quite easily. It is easily available in most of the centers. However, if we do a skull X-ray, the disadvantage is that we cannot look into the brain parenchyma itself. We can only look at the bony fractures, but we are unable to identify whether the child has any intracranial bleeding or not. So that leaves us with CT scan. So CT scan is deemed the most appropriate imaging modality for children with suspected traumatic brain injury and required an imaging to be done. So for CT scan, yes, there will be some radiation risk. However, with a CT scan done, a CT brain done, we will be able to look at the brain parenchyma to look for any intracranial bleeding as well as any bony fractures that we are able to identify. So, as in the previous slide, I was talking about the risk of radiation if we do CT scan, right? So here, I'm here to share with you all this principle called the ALARA principle, what we call as low as reasonably achievable principle. So as we know, the radiation exposure from CT scan in childhood can lead to a risk of leukemia and brain tumor. And the cancer incidence rate is 24% higher for patients exposed to childhood and adolescent radiation. Thus, the ALARA principle comes in, where the clinician will decide the risk and benefit of doing a CT scan compared to the radiation risk that is involved. And nowadays, in this modern world, we do know that in a pediatric, a women and children hospital, the pediatric radiologists have the CT scan machine that can provide a lower radiation frequency. So in order to aid us of whether an imaging is necessary or the child can be observed after the traumatic brain event, so there are some clinical decision rules that we need to be aware of. So we have CATCH, PICAN, CHALICE, PREDICT, and even the NICE guideline. So let us have a quick run through of the history of all these clinical decision rules for traumatic brain injury. So way back in 2001, the Canadian City Head Rule sets in. And this was done in the Canada. And 2 years later, the NICE guideline comes in. And then in 2006, the CHALICE clinical prediction rule comes in. And later down the line, in 2009, the PICAN rule comes in. And in 2010, the CATCH rule comes in as well. And eventually in 2012 to 2014, there are studies that were done to compare all these clinical decision rules, which I'm going to share with all of you in a short while. And this is one of the latest guideline that is available for children with mild to moderate head injuries, which we call the Pediatric guideline. And this was published in 2021. So now, let us have a look at one of the clinical decision rule, the Chalice rule. So Chalice rule is based from the UK. So it was done in multi-center UK hospital, and it involved about 22,000 of children with the age of less than 16 years old. And the goal in this study was to identify patients with clinically important traumatic brain injury, where they categorize them as high-risk TBI. And for this clinical decision rule, they only take in patients that present to the hospital within 24 hours of injury. And they also include mechanism of injury during the risk stratification, as you can see at this table next to you. How about Pecan rule? I'm sure some of the hospitals are using one of these clinical decision rule where I'm going to talk about. So Pecan rule is from the States. It is called the Pediatric Emergency Care Applied Research Network, all the way back in 2009. And in this study, they took in double the amount of patients that was done in Chalice. They took in about 42,000 of patients, and the patient age range around up to 18 years old. And they also take in the patients that present with head injury within 24 hours of trauma. And their goal is to identify low-risk patients with clinically important traumatic brain injury. So based on this, they re-stratify patients into 3 categories, where low risk, no CT will be warranted; moderate risk, then it will be a decision between observation or performing and CT imaging; and of course, if high risk, then a CT brain would be warranted. And later on, the catch rule comes in from the Canada, which is the Canadian Assessment of Tomography for Childhood Head Injury. So in this trial, they enrolled only about 3,866 patients with the age range up to about 16 years old. And they also take in the time of presentation within 24 hours of injury with a Glasgow Coma scale of 13 and above. And their goal is to identify any high-risk clinically important traumatic brain injury. So, with all these clinical decision rules, which one is more superior to the other? Well, the answer is none. Thus, in 2012 up to 2014, there are multiple studies that has been done to compare all these clinical decision rules. Okay, so in this comparison study, they are trying to compare mainly the Pecan rule, the Catch rule, the Chalice rule, as well as the physician judgment in handling clinically important traumatic brain injury or in children with minor head injury. So what were the findings? So as you can see in this green table that I've shown, so based on the clinical decision rules comparison as well as the physician judgment, they listed down the sensitivity and the specificity of each clinical decision rule in comparison with the physician judgment. So in Pecan rule, we can see that it's 100% sensitive and it has a specificity of about 62%. Whereas in the Chalice rule, the sensitivity dropped a bit to about 84% with a higher specificity of 85%. And in the Catch rule, it has a higher sensitivity of 91% but a very low specificity of 44%. And if you can see, under the physician judgment, the sensitivity and specificity is more or less similar as the Pecan rule, where the physician judgment has a sensitivity of 95% and a specificity of about 68%. Okay? So, this head injury clinical decision rule comparison was published in the Pediatric guideline. So, from this, we are able to summarize that the clinical decision rules are all sensitive, and this will help the clinicians not to miss any significant or clinically important pediatric traumatic brain injury. And we can see that from the table that I've shown earlier, the Pecan rule is the most sensitive, whereas the chalice has most easy to apply to everyone. But do bear in mind that the clinical decision rule do not replace the clinical judgment. This from Pecan rule. Okay? And from this, they re-stratify again into high risk, where you can see at the top left corner, the lower left corner, where it's all written in red. If the child fall into the high risk, then an imaging would be warranted, and a neurosurgical consult and admission would be warranted as well. If the child falls into the intermediate risk, this is where we need to, the clinician needs to come in and decide whether observation would be beneficial or imaging would be beneficial for the patient according to the algorithm pathway. And if it is low risk, which is colored in darker green, then the child can be discharged with advice if no other factors requiring admission. And if it is very low risk, which is in light green, then the child can be discharged as well. And in this Pediatric guideline, as we can see, there are some components of special conditions or special considerations that they talk about. So they also talk about abusive head trauma, or those children that are drug or alcohol intoxicated, and they also consider about children that are less than 6 months of age, or those special children with neurodevelopmental disorder, on how to differentiate this from a head injury, and as well as children with ventricular shunts and bleeding disorder. So later on, when you are free, you can have a look. Just Google the Pediatric guideline, and you can download the whole guideline for free. So next, once we have decided whether whether children with mild traumatic brain injury would require an observation or imaging based on the clinical decision rule as well as the physician judgment, then now I'm going to go into the part where how do we manage moderate to severe TBI, and what are some of the management components that are involved. So of course, first, you need to look into the respiratory monitoring and management. This is where we talk about adequate oxygenation to avoid neuronal ischemia, and we aim a target of a PaO2 of more than 80 mm mercury. So studies have shown in both adult and pediatric population that hyperventilation results in a decreased cerebral oxygenation, and it can induce brain ischemia. So do remember, avoid prophylactic hyperventilation to a PCO2 of less than 30 at the initial 48 hours of a traumatic brain injury. So we have to keep the PaCO2 between 35 to 40. Alright? Next, after we have dealt with the airway and respiratory monitoring and management, then under the circulation component, we need to be aware that in In cases of severe traumatic brain injury, any hypotensive episodes will double the mortality rate. So when we talk about fluid resuscitation, you will use an isotonic solution. Try to maintain the mean arterial pressure between 60 to 80 millimeter mercury. And sometimes in younger children, it depends on the age group. And also try to fix any source of bleeding that can be seen over the external head, especially the scalp area. Okay? And if there is a need to, you might need to add on some vasopressor to keep the mean arterial pressure more than 80 millimeter mercury. And always be aware of Cushing's reflex. When you notice there is hypertension and bradycardia in children, that is actually a very late sign. We will try to prevent this Cushing reflex from happening. And also do remember, head positioning is utmost important as well. Ensure a child with a traumatic brain injury, they are positioned with 20 degrees head up. So this is based on the APLS, the 7th edition, the latest edition. And how about seizure prophylaxis? As we have seen in adults, seizure prophylaxis is warranted in certain conditions. So this is the same for in children in the pediatric population. So some of the risk factors that we look into in order to help us to guide whether a seizure prophylaxis should be initiated or not are if those children with traumatic brain injury and retained bone and metal fragments, those with depressed skull fracture, those with focal neurological deficits, or those children that come in with loss of consciousness or semi-conscious, those with the GCS of less than 10, or kids with traumatic brain injury and they sustain subdural or extradural hematoma, or children with traumatic brain injury but the mechanism of injury is a penetrating type of injury. And always remember that infants and children have a lower threshold, seizure threshold compared to adults. And usually, seizure prophylaxis for the first 7 days after a traumatic brain injury is recommended. And we will usually treat with benzodiazepine for immediate control of seizure. Some patients you might consider to load with IV phenytoin or levetiracetam. How about glucose control? Well, there are articles that saying that we need to ensure there is a tight glucose control or prevent hyperglycemia as well as preventing hypovolemia. So what does the study says? So in this study done by Chong et al. For early hyperglycemia in pediatric traumatic brain injury, so they noticed that actually hyperglycemia is associated with poor outcomes in children with traumatic brain injury, where it will cause an impairment in the cerebral autoregulation. So in this study, they stated that there is no optimal target range in the setting of traumatic brain injury in the pediatric population. And there is another study which was done in a PICU setting, and this was published in the New England Journal of Medicine. So they did a randomized control trial of comparing a tight glucose control of maintaining the glucose level between 3 to 6 to another group of just less than 10 millimole per liter. So the outcome that they measure was the number of days alive and free from mechanical ventilation at 30 days of randomization. So in the conclusion, they noticed that there is no significant effect on major clinical outcomes in both groups. Just that there is incidence of higher incidence of hypoglycemia in those children with a tighter glucose control group. And in a traumatic brain injury, We also talk about hyperosmolar agent, especially in children that has traumatic brain injury and raised ICP symptom. This is when the hyperosmolar agent comes into play. And I think, as you all know, we have two major hyperosmolar agents, mannitol as well as hypertonic saline. So which is better? So let us talk about mannitol first. So the mannitol that we usually use is the 20% mannitol, where we give a dose of 250 to 500 milligram per kilo over 20 to 30 minutes. And what does mannitol do? It will help to reduce the blood viscosity, and mannitol will have osmotic effect, where it will move the water from parenchyma into the systemic circulation. So by this mechanism of action, mannitol may accumulate in the injured brain regions where the reverse osmotic shift may occur, with fluid moving in from intravascular component into the brain parenchyma, and this will lead to a worsening of the raised ICP. And when there is a fluid shift from the intravascular to the brain parenchyma, this can also cause hypovolemia. And in the Brain Trauma Foundation in 2000, they noticed that the use of mannitol may develop the risk of acute tubular necrosis as well as renal failure. So should we use mannitol? Or should we go into another option, which is the hypertonic saline? So hypertonic saline is a 3% normal saline, where we give it over 3 ml per kilo over 10 to 20 minutes. But for hypertonic saline, unlike mannitol, they do not cause any profound osmotic diuresis, and the risk of hypovolemia is much more lesser compared to mannitol. Hypertonic saline helps to restore the normal cellular resting membrane potential, as well as inhibits inflammation, and it helps to enhance the cardiac output. The only side effects that we need to be aware of is it can cause osmotic demyelination, where it will lead to central pontine myelinosis and some patients heart failure. Okay. So based on the studies that has been done, in all these large observational studies, it has been proven that hypertonic saline perform much better compared to mannitol in terms of aiding to lowering the raised intracranial pressure in pediatric traumatic brain injury. And this also support the current guideline done by the Brain Trauma Foundation, where we should be using hypertonic saline as the first-line agent. How about role of observation for head injury? So, as we know, for mild traumatic brain injury with the GCS of 14 and above, if it is a trivial injury, the mechanism of injury is very trivial, there is actually no role for any observation. And they also noticed that the role of observation for minor head injury has lowered the rates of cranial CT in observed patients, where there is a reduction of 35% to become 31% of pediatric patients that need to undergo CT. And in the latest Predict 2021 guidelines, it is more descriptive, where they recommend an observation time period of about 4 to 6 hours based on the clinician judgment. And in this Predict guideline as well, they listed down the discharge criteria for pediatric patients with mild head injury. So we need to ensure, if a child presents to you with mild head injury, then you will need to ensure that the child is acting normally with the parent for at least an hour, normal neurological examination, and can tolerate orally. There are no other factors that warranting admission or prolonged observation after the initial observation for about 4 to 6 hours. Okay? And head injury advice has been given to parents, and parents understand on how to monitor the child at home. And they also give a discharge criteria plan where there will be a 1 to 2 weeks follow-up with the primary care to assess post-concussive symptom. So, in summary, in this for caring for kids with head injuries, so first you must always remember what are the questions to ask, how to take a proper history in children with suspected head trauma, and then we must assess properly and decide on whether there is any role of imaging versus observation. And then we also talk about the choice of imaging for children with head injuries. And I introduced about the ALARA principle. And also there is a comparison of all the types of clinical decision rules to aid in our decision for neuroimaging in traumatic brain injury in children. But always bear in mind as well that the clinician judgment is also crucial. And then we talk a bit about the role of observation versus imaging in mild traumatic brain injury in the pediatric population. And also further exploration of patients with traumatic brain injury with complex issue, and what are the discharge criteria for children with head injuries as listed in the slide before this. So that will be the end of the webinar session today, and these are my references. So feel free to drop in any questions if there are any questions or uncertainties that you would like me to answer, and I will get back to you. Thank you.